where does carbo fit in? I mean, you're presenting data on carbo, at least in the neoadjuvant setting in these patients. I mean, where does carbo fit into this whole?
So we present data on survival from the GeparSixto trial at this meeting. Bottom line, neoadjuvant trial powered for PCR, but obviously now we have a 5-year disease-free and overall survival data. We have a survival benefit in GeparSixto with the addition of platinum, but unfortunately, I have to confess, in the control arm, we didn't take the alkylating agent, cyclophosphamide. Now, we have done a similar trial in which Hope Rugo and myself were involved. The Brightness trial presented at ASCO 2017. It was a positive trial for the addition of platinum, and it was not positive for the addition of veliparib, another PARP inhibitor, in addition to platinum. So basically, the PCR as an endpoint could not be made even better with the addition of veliparib in patients who had already a significant benefit for platinum. So in Germany, in our national guideline, triple-negative breast cancer patients have, on a routine basis, platinum in the neoadjuvant setting, in addition to anthracycline and taxane. I'm excited about all PARP inhibitors. I would not say which of the PARP inhibitors coming now or are already on the market is better or not. And it seems that I'm the only GYN oncologist here on this table. I treat a lot of ovarian cancer patients. Now, in ovarian cancer, PARP inhibition is one of these successful stories of the last years. We have olaparib approved, and we have now niraparib approved from Tesaro. And these two drugs make the natural history of this devastating disease very different. I have really long time responders in more than 2 years with the addition of a PARP inhibitor in otherwise patients who would have died of their ovarian cancer.
So, but that's an interesting. So, in ovarian, though, you use it as consolidation, right?
Well, as
you
consolidation.
give people platinum-based therapy and then consolidate.
Yeah. But Joyce
is that a
gave
strategy in breast?
Yeah, but Joyce gave a very good example. I mean, it was an anecdotal example. But I like this example because it fits with the ovarian cancer story.
Right.
But, you know, this is what's going to be, hopefully, or actually it's underway in the early breast cancer setting. I mean, in the adjuvant Olympia trial, this is what we do. What I think is, you know, clearly it is fascinating that we now, and we have been discussing a lot with luminal subtype catching up with HER2-positive disease, and finally for triple negative, which was we were more or less desperate for a decade or so. I think there is now innovation that's going to benefit our patients. And you know, what I'm interested in is it appears to be very clear for germline mutated patients. But obviously there are other patients.
Right, who should benefit?
BRCA, you know,
what
what test to use.
The PARP I7 from I5, what should we be using?
Yeah. Well, that's,
but that's the potential of this is that it can probably expand, probably double, approximately double the number of patients who can benefit from these innovative agents.
One question, I mean, I know it's uncommon, but I've started to see a few somatic BRCA mutations. And would one expect, if you say did a foundation or some next-gen sequencing and found a somatic mutation, would these drugs work, would these agents work?
We have the experience from the ovarian cancer, and it has been proven that patients who do not have a germline mutation but have a somatic mutation have an excellent response to
so
these
we do have
class of
evidence
drugs.
from another disease.
We have evidence.
That's and the niraparib trial showed that, but it's such a different disease.
But, well, again, it's ovarian cancer.
It is.
But
Works in wild type.
let's do some more clinical work, some more trials. I expect to see a very similar story in triple-negative breast cancer.